Hello everyone. So today's topic for discussion is anatomy of pulp cavity. Of all the phases of anatomic study in the human system, one of the most complex is the pulp cavity morphology. The pulp cavity is a central cavity of the tooth. Now, Cohen had defined pulp cavity as the entire space in the dentin where the pulp is housed. Pulp, as we know, is a blood supply to the tooth structure and is a light tissue that is supporting the tooth structure. It is entirely enclosed by the dentin except for the apical foramen. The pulpal cavity of a tooth, we can divide it into two parts. The upper portion or the coronal portion, which is known as a pulp chamber, and the radicular portion or the lower portion, which is known as the root canal. Together, it is known as the pulp cavity. Now, we'll discuss about pulp chamber. So, pulp chamber in an anterior teeth gradually merges into the root canal system, and this division becomes indistinct. But in a multi-rooted teeth, this distinction can be seen. That is, a single pulp chamber will be there, dividing it into different root canal systems, and each teeth will be having different number of canals. It's not constant. And the number of canals can also vary from 1, 4 or even more. Now, now we'll discuss about the different parts of the pulp chamber. So when we consider the pulp chamber, we can imagine it to be a box-shaped cavity. Just like a box, there's a roof, there's a floor, and there is walls. So a pulp chamber of a multi-rooted teeth will be having a roof that is known as the roof of the pulp chamber. Roof of the pulp chamber is the dentin that is covering the pulp chamber occlusally or incisally. The next part is the pulp horn, which is an exaggeration of the roof of the pulp chamber directly under a cusp or a developmental lobe. Then there is a floor of the pulp chamber. The floor of the pulp chamber runs parallel to the roof and consists of dentin bonding the pulp chamber near the cervical area of the tooth. Then the fourth part is the canal orifices. These are canal orifices that is found on the floor of the pulp chamber. These are openings that is seen leading into the root canal system, the rest of the root canal system. The canal orifices are not separate structures, but they are continuous with both the pulp chamber and the root canals. Okay. The walls of the pulp chamber derive their name from the corresponding walls of the tooth surface, such as the buccal wall of the pulp chamber is coming from the buccal surface of the tooth structure. Okay. And the angles of the pulp chamber is derive their name from the walls forming the angle, such as the mesiobuccal angle of the pulp chamber. So we can see that there is different parts of the pulp chamber. Which are the different parts of a pulp chamber? The pulp chamber consists of the roof of the pulp chamber, which is the dentin that is overlying occlusally or incisally the pulpal cavity. Then there is the pulp horn, which is an exaggeration of the roof of the pulp chamber. That will be corresponding cusp. It will be under the corresponding cusp. Then there is the floor of the pulp chamber, which is parallel to the roof. The canal orifices, which are the openings that is continuous with the root canal system. There is walls of the pulp chamber and angles of the pulp chamber. The walls derive their name from the surface which is corresponding, and the angle of the pulp chamber is an angle that is formed between the wall and the angle. Okay, so that is about the different parts of a pulp chamber and what a pulp chamber is. Now, the root canal is a portion of the pulp cavity from the canal orifice to the apical foramen, and in order for the convenience, it has been divided into the coronal part, the middle part and the apical part. Coronal part is where the orifice is present. The apical part is the end of the root canal system and where most of the ramifications or extra canals are present. Now, let's see about accessory canals. Accessory canals are canals that extend in a horizontal, vertical or lateral direction from the main pulp canal to the periodontium is known as the accessory canals. According to Cohen, accessory canals is more in the apical third, that is about 73.5% of accessory canals is present in the apical third, 11.4% of accessory canals is present in the middle third and 15.1% of accessory canals are present in the cervical third. These are connective tissue and vessels, but they do not supply the pulp with collateral circulation. They are formed by the entrapment of the periodontal vessels in the Hardwick's epithelial root shed during calcification. Okay, so that is about the accessory canals. A distinction sometimes is made between an accessory canal and a lateral canal is that a lateral canal is an accessory canal that branches to the lateral surface of the root and may be visible on a radiograph. Now, accessory canals are there. There are different types of accessory canals. They are the percussion canals and the lateral canals. Now, this is a tooth structure where we can see the accessory foramen. The percussion canal is the accessory canal that is present in the bifurcation or trifurcation of a multi-rooted tooth. It is formed during the entrapment of the periodontal vessels during fusion of the diaphragm area of the tooth structure. And lateral canal, which is an accessory canal that branches to the lateral surface of the root. The lateral canals with small arterioles and venules serve as collateral circulation, but not that much. When the pulp becomes diseased, Shelder referred to them as portal of exit for the infections into the tooth structure from the periodontal ligament space through the ligament space. So, the accessory canals can be divided into the percussion canal and the lateral canals, where the percussion canal is the accessory canal that is seen in the bifurcation areas or trifurcation if it is multi-rooted tooth, and lateral canal is the canal that is seen on the lateral surface of the root where it is connected to the periodontal space. The accessory foramen is the opening of the lateral canals into the periodontal space. Okay. The apical third is the highest percentage of ramifications and accessory canals. These ramification and accessory canals are increasingly eliminated by apicoectomy or root resection during apicoectomy. Reason for removing the apical, that is mostly ideally the during apicoectomy we remove about apical 3 mm of the root is resected out. Why? The reason is that in studies it has been shown that 1 mm of root and resection will result in only 52% of ramification, including about 52% of ramification and accessory canals. In 2 mm of root and resection, only about 78% of accessory canals and ramifications can be included. But when we include a 3 mm of root and resection, a 98% of ramifications and accessory canals can be included in the procedure, okay, and included in the apical area. So, we can see that those areas which is having more number of apical ramification and accessory canals will be included during root and resection. So, it leads to more success rate of the apicoectomy. And after apicoectomy, of course we have to seal the apical area. Now, apical delta is the primary or secondary canals that terminate short of the apex with lateral canals fanning out from this point to the end of the root surface. Now coming to the anatomy of the root apex, the classic concept of an apical root anatomy is that there exist three anatomical and histological landmarks. They are the minor apical diameter or the apical constriction, the major apical diameter or which is known as the apical foramen, then there is the cemento-dentinal junction. So these are the three main anatomical and histological landmarks of a apical root or the root apex. Now we will describe each in details. Coming to the apical constriction or which is known as a minor apical diameter, Cutler had described the anatomy of the root apex as the narrowest diameter of the canal from the tooth but usually occurs within the dentin just prior to the initial layer of cementum. This position is known as the minor diameter, which is also called the apical constriction. So, it is the narrowest diameter of the canal from the tooth but usually occurs within the dentin just prior to the initial layer of cementum, and it is a part of the root canal with the smallest diameter, and also it is the reference point for apical termination during a root canal therapy. The distance ranges from 0.5 mm to 1.5 mm inside the apical foramen. So, from the apical foramen or from the major apical diameter, it is about 0.5 mm or 1.5 mm inside the apical foramen. Okay, that is why we actually measure the that is during root canal treatment, we measure the length of a root canal or canal will be measured 0.5 mm short of the apex. That is about the apical constriction or the minor apical diameter. Now we will discuss about the cemento-dentinal junction. In young, incompletely developed teeth, the apical foramen is funnel shaped with a wider portion extending outwards. The mouth of the funnel is filled with periodontal tissues that is later replaced by dentin and cementum, that is in the young teeth. As the root develops, the apical foramen becomes narrower and the inner surface of the root apex becomes lined with cementum, which may even extend for a short distance into the root canal. The cemento-dentinal junction is therefore does not necessarily occur at the extreme end of the root, but may occur within the main root canal system. Consequently, it is not necessary to clean, shape or fill a root canal to their anatomical apex, but rather to the cemento-dentinal junction, which usually lies within the canal just short of the apex. So, it is usually approximately 1 mm from the apical foramen, and it is a point where the cementum meets the dentin. That is known as a cemento-dentinal junction, and it is not at the anatomical apex. That is about the cemento-dentinal junction. Now, when we see the apical foramen, which is also known as the major apical diameter, it differentiates the terminal of the cemental canal from the exterior surface of the tooth surface. The apical foramen is not always located in the center of the root apex. It may exit on the mesial, distal, labial or even the lingual surface of the root, usually slightly eccentrically. Anatomical studies have found that the apical foramen coincides within the anatomical apex only about 17 to 46% of the cases. It is located at an average of about 0.4 to 0.7 mm away from the anatomical apex, and in a few cases the apical foramen has been found as much as 2 to 3 mm away from the anatomical apex. These studies have led to the recommendation that root canal obturation should end approximately 0.5 mm from the anatomic root apex as seen in the radiograph. The diameter is almost double the apical constriction, giving it a funnel shaped appearance, and also it is known as the morning glory or hyperbolic appearance. The mean distance between a major and a minor diameter is about 0.5 mm in young individuals and 0.7 mm in older individuals. There are always two apexes recognized for any tooth, that is the radiographic apex and the anatomical apex. The radiographic apex, it is the external border of the root tip which is seen radiographically, and the anatomic apex is the natural apical constriction formed by the cemento-enamel junction. A straight root canal extending the entire length of the root is uncommon. Either a constriction is present before the apex is reached, or as is often the case, a curvature is present. The curvature may be having a course of four directions, or four nature of course will be there. One is a curved root canal with apical foramen distant from the apex. 2 is a curved root canal with apical foramen near the apex. 3 is a constricted root canal as the apical foramen is approached. And 4, which is a double curvature of the root canal with the foramen at a distance from the root apex. A curvature of about 20 degree in a narrow root canals may be difficult or even impossible to negotiate with an endodontic instrument, whereas a curvature of about even 30 degree may be negotiated if the root canal is wide. The curvature can be a gradual curve of the entire canal or a sharp curvature near the apex. The curvature can be in a facial lingual direction. It can possess a problem during enlargement and shaping procedures. The success in negotiating a narrow curved canals depends on four factors. They are the degree of curvature, the size and constriction of the root canal, the size and flexibility of the endodontic instrument that is used, the skill of the operator. Now, the canal curvature can be classified. There are three types of classification that is seen. There is the Schneider's classification, the Dobo-Nagy classification, the radius-based classification of the curvature. Now, when we consider the Schneider's classification, if the angle of curvature is less than 5, it is known as a straight canal. If the angle is about 10 to 20 degree, then it will be moderately curved. And if the angle is more than 20, it is severely curved. In severely curved canals, it is possible that instrument can get separated. That is the Schneider's classification. Now coming to the Dobo-Nagy classification, if it is an eye-shaped, it is divided into four types. The straight or the eye-shaped curvature, a J-shaped curvature or the apical curve, C-shaped curvature or the entirely curvature, and an S-shaped curvature which is having a multi-curve. Then there is a radius-based curvature where again if the radius is less than 4 mm, then it is known as a severely curved. If it is more than 4 mm but less than 8 mm, then it is moderately curved, and if it is more than 8 mm, it is mildly curved. So that is about the classification of a canal curvature. Now let's discuss the canal isthmus. What is a canal isthmus? It is a ribbon-shaped communication between two root canals that contains pulp or pulpally derived tissues. It is found that the percentage of occurrence of isthmus increases continuously for every 1 mm from the apex for the first 4 mm of the length from the apex. Isthmus can be of different types. They are type 1, which is an incomplete isthmus, that is, there is a faint communication between the two canals. Then there is type 2, which is characterized by two canals with definite communication between them. Type 3, which is a very short, complete isthmus between two canals. Then there is type 4, which is a complete or an incomplete isthmus between two or more canals. Type 5 is marked by 3 or 2 canals openings without visible connections. So that is about the different types of isthmus. Okay, and there are other classifications also, like there is Sue and Kim classification, where it is said that there is type 1, type 1 which is 2 or 3 canals with no communication between them, type 2 which is 2 canals with a definite communication, type 3 which differs from type 2 due to the presence of a 3 canals instead of 2 canal. It's an incomplete C-shaped canal with 3 canals included. Then there is type 4, which is canals that is extending to the isthmus area, and type 5, which is a true connection or a corridor throughout the section. So that is about the canal isthmus. Canal isthmus is important during a root canal treatment because it consists of connective tissue, periodontal, blood vessels present, and it can cause problem in a longer duration. Even after root canal system or root canal treatment, it can cause problem to the tooth structure. So it is necessary and it is very important that we clean the canal isthmuses also. It is usually done during the root canal treatment. That is why the canal isthmuses is important. So with that, I am ending today's topic. Thank you, and do leave your comments below.